let's talk about acute painful shoulder. Acute painful shoulder can be because of two conditions, either because of traumatic or it could be non-traumatic. So let's concentrate on a non-traumatic acute painful shoulder conditions. So there can be many conditions which can cause acute painful shoulder. For example, frozen shoulder, calcific tendonitis, um, adhesive capsulated, which for example once again is frozen shoulder, another name for frozen shoulder, bursitis, rotator cuff pathologies, impingement syndrome, or acute flare-up of osteoarthritis, rarely infection, post-traumatic stiffness, etc. So in this particular lecture, we'll concentrate on acute calcific tendonitis. So acute calcific tendonitis of shoulder is a painful condition of a shoulder caused by deposition of calcium hydroxyapatite crystals in shoulder muscles. The shoulder muscles mainly affected because of this calcific deposition are rotator cuff muscles. There are 4 rotator cuff muscles. In the front, you have subscapularis, supraspinatus in the top, infraspinatus and teres minor in the back. So why does calcium deposition causes pain? So if you look into the pathophysiology, the lack of blood supply, or what we call as local ischemia, incites fibrocartilaginous metaplasia in the part of the affected tendon. And these chondrocytes stimulate calcium hydroxyapatite deposition in the affected part. If you look into the 4 different tendons, supraspinatus is the commonest tendon affected. So why does this deposition should cause pain? This is because of 2 reasons. One, because of the chemical irritation incited by the deposition of the calcium hydroxyapatite crystals, or second one is because of the intense pressure which can build up within the tendon itself because of the calcium deposition that can cause pain. So because of both of these, they can cause impingement syndrome on certain movements, which can cause pain as well. So these are the reasons why a calcific deposition can cause pain. So who gets affected, or why does it develop in certain people? So the cause is unknown. It's an idiopathic condition. If you look into the pattern, there are a lot of patients within the age group of 30 to 50 are commonly affected. It's common in diabetics as well. The features of acute calcific tendonitis. The clinical symptoms, if you look into the typical patient walking into the clinic of typical age would be between 30 to 50, maybe diabetic. They report a diffuse pain across the shoulder, and some patients may report loss of movement as well. If you, in the clinical examination, you may find diffuse tenderness across the shoulder. Sometimes it may be just on the lateral aspect of the shoulder as well. And classically, they report painful arc of motion between 60 to 120 range of movement, between somewhere around 60 to 120 degrees. And depending on the extent of disease, they may have positive impingement signs such as Hawkins Kennedy test, knee test, etc. How can we diagnose a patient with acute calcific tendonitis? One, clinical history and examination. Second is investigation, which is plain X-rays. Plain radiographs are very useful in diagnosing acute calcific tendonitis. In a neutral AP X-rays, we can locate the supraspinatus tendon calcific deposit. With the internal rotation AP X-rays, we can visualize the posterior aspect of the tendon, which, for example, infraspinatus and teres minor calcific deposits can be visualized. And with the external rotated views, we can visualize the subscapularis calcific deposits as well. Ultrasounds are useful. In case if you have a calcific deposits in X-ray and patient report weakness, and if you have a positive test for a weak rotator cuff to diagnose a rotator cuff tear, ultrasound may be useful. In some cases, most of the clinical features are suggestive of calcific tendinitis. X-ray is not conclusive. In those circumstances, ultrasound may pick up the very initial stages of calcific deposits. MRI and CT scan are of not much use in acute calcific tendinitis. So, if you look into how to classify calcific tendinitis, there are a few classifications which are worth mentioning. There is a Bosworth classification, which takes into account of the size of the calcific deposits which appear in a plain radiographs. If the size of the calcific deposit is less than 0.5 centimeter, it's classified as small. If it is between 0.5 to 1.5, it's classified as a medium. Anything larger than 1.5 centimeter is classed as a large calcific deposit. Apart from this, there is another classification which is worth mentioning as well, because it has some significance with the management plan as well, which is De Palma and Kruper classification. Depending on the appearance of the calcific deposits in the plain radiographs, it's irrespective of the size. It's classified into type 1 and type 2. In type 1, the calcific deposits appear as a fleecy, fluffy, ill-defined deposit, which corresponds to a resorptive stage of calcific tendinitis. In a type 2, it's a well-defined, homogeneous, discrete calcific deposit, which corresponds to a formative stage of the pathology. Let's look into the treatment of acute calcific tendinitis. So, treating calcific tendinitis depends on what stage of the disease in the radiographic findings, right? Whether it's a formative stage or is it a resorptive stage, and also looking into the clinical features. There are two options: non-operative methods and the operative methods. Majority of the patients get better with the non-operative measures itself, such as anti-inflammatory medications. NSAIDs will control the inflammation, thereby the pain. Physiotherapy to improve the range of movement. For example, in a supraspinatus calcific deposits, the abduction is limited, so the physiotherapy can improve to help the range of movement. Steroid injection into the suboptimal space may control the inflammation associated with the calcific deposition and may help to reduce the pain. Recently, ultrasound guided barbotage and irrigation of the calcific deposit has been tried. It's very effective in the resorptive stage of the disease process. Ultrasound guided barbotage helps by two ways. One, physically removing the calcium deposit. Secondly, by stimulating a cell-mediated resorption of the calcium deposits itself. And also recently, shockwave therapy to resolve the calcium deposits also have been tried. So, after all these conservative measures, if the symptoms are not resolved for more than 6 weeks or so, or for between 6 weeks to 6 months, then operative treatment does play a role. And operative options could be either arthroscopic or mini open, and recently arthroscopic techniques have taken a major role. In arthroscoping, mainly go to the subacromial space and physically removing the, first of all, we have to identify the location of the calcific deposit by making using a needle, and then once we identified the calcific deposit, and we have to physically remove it and irrigate the area as well. Acute calcific deposits, acute calcific tendinitis can cause few complications. It can cause rotator cuff tear. Impingement syndrome is it's a result of sometimes calcific deposits and positive impingement because of the bursitis as well.